All right. So I again would like to thank the organizers for inviting me to come and talk about this. My lab has been focused on in vivo analysis of tissue reservoirs and inflammatory damage from HIV replication. And what I'd like to talk about today briefly is undetected HIV under antiretroviral therapy. What does it mean and how can we measure HIV persistence? Okay, it's not doing anything. So it's not advancing? I did that.
Oh.
That one too?
Okay, how many PhDs and MDs do we have up here?
Yeah, sometimes they freeze.
Yeah, it did a little funny there.
It's frozen.
Let me,
Okay.
I'll have it someone down here
Go
in
ahead,
2
you
seconds.
can do this without slides, right?
I can. Actually, I was telling Sarah that last night I got here and I started to work on my talk. I had it up in the cloud, whatever that is, and the original talk is still there. So I had to put it all together. Huh? Maybe it'll rain, exactly. Well, all right. So our lab has been working on this problem of locating tissue reservoirs of HIV for some time, and I think the main difference between what we do and all of the elegant assays that Sarah and others have told you about is that when you look in using histologic analysis and when you can actually locate where the reservoir is anatomically, spatially, you can use double label experiments to determine what the phenotype of the cell that's expressing RNA or that is DNA. Are we there? Positive. Okay, we're still not moving. Can you switch the slides from somewhere else?
Is it working again?
No. Is it? Hey, all right. So I want to have this discussion, frame it around what you've heard about with the Mississippi baby. And one of the things that happened after the child rebound was the discussion was, where did the virus come from? And I'd like to use the tools and techniques that we've developed over the years and the reservoir studies that we've done to try and look at that question and maybe put a little bit of clarity around that. So I always like to start these discussions with what we know that we know. And in particular, we know that HIV preferentially replicates in CD4 T cells, and we could discuss at length, and probably you have, the role of macrophages. But I think for purposes of this discussion, we'll assume that macrophages are capable of productive infection, and we need to account for them as we do our catalog of reservoirs in the tissues. Most CD4 T cells reside in lymphatic tissues, either lymph node, secondary lymph node, or gut-associated lymphoid tissue. And in CD4 T cells, you can talk about, in these CD4 T cells that you see here, you can have latent infection, or the cell can be productively infected, expressing HIV RNA to various levels. The same for macrophages. But I think an under-talked about potential reservoir is the B-cell follicle and the follicular dendritic cell network that is part of the B-cell follicle. HIV is made in T cells in the parafollicular T cell zone, and then it can be, via antigen complex, brought in and attached to the FDC network. And we know, Greg Burton has shown us that it can stay there for an extended period of time, and then it can come off and initiate new rounds of replication. Our lab uses in situ hybridization to look at this. This is HIV RNA in situ hybridization. So you can see in the parafollicular T cell zone these cells that are productively infected. You can count those, you can measure the tissue, and you can get a quantitative assessment for the frequency and the number of these cells that exist. This is the B-cell follicle and the virus that's attached to the FDC network. We, again, just like with the T cells, we can quantitate that and begin to make measures of what the size of the reservoir is, at least for RNA. We can use double label experiments, as I explained before. In this slide, you see CD3 positive T cells. In green, we've used a DIG probe to label SIV RNA positive cells, and these white arrows indicate cells that are double positive, i.e. they're T cells, and the yellow arrowheads are cells that are not CD3 positive, but are expressing SIV RNA. So we can use these tools to assess the size, location, and frequency of the reservoirs, et cetera. The real question, of course, is DNA, and at least using histologic analyses, that's been a tough nut to crack. Ashley Haas in 1993 showed using in situ PCR that he could detect the size, location, and frequency of DNA-positive cells, but that was an extraordinarily difficult assay, hard to reproduce, et cetera. Jake Estes has recently developed a very nice, elegant assay using a DNA scope platform, and what you see here are ACH2 cells using this DNA scope, and the cells that are DNA positive, you see the signal accumulating over the nucleus. It's a small punctate, red appearing cell, and we can quantitate that as well. So let's put all of these tools together and really try and understand where the reservoirs are and what they're doing. To do that, we took 3 animals, 3 non-human primates, 3 rhesus macaques. We infected them with SIV251. At day 10, 30, and 75, we sacrificed them, and we just went from top to bottom, looking throughout the entire animal for where the reservoir of infection was, first by RNA. And these are the results. So the primary reservoir of SIV RNA positive cells is in the lymphatic tissues, and this, again, was shown in 1997 in a nice JID paper by Todd Reinhardt, and earlier by Ashley and Gepi Panaleo. But if you look in the non-lymphoid compartments, heart, lung, liver, kidney, you do see some evidence of RNA-positive cells. Most of those are CD3-positive cells using double label experiments. But the real story is in the lymphoid compartment, and there it's at least 2 to 3 logs higher in terms of RNA-positive cells per gram than in non-lymphoid compartments. We have an ongoing study in Uganda with the Joint Clinical Research Center where we're looking at reservoirs in patients before and during therapy, and we get exactly the same number as we do in the non-human primate model. So it's about 10 to the 6 cells per gram that are expressing HIV RNA in the untreated patient. We can look, as I said, in the FDC network. When we do those calculations, you can see that it's about 10 to the 8th copies of HIV RNA per gram of tissue. So you're now getting a sense for how big this reservoir is in the untreated individual. Looking with DNA scope, we find that it's about 10 to the 9th cells per gram of tissue, and this is almost exactly the same number that Ashley Haas got with his in situ PCR in 1993. But this assay can be done in 24 hours. It's very fast, so it's very robust. And then looking in the Ugandan patients, we see almost the same exact number. Interestingly enough, and I know others have shown this with molecular assays, but when we look over time in lymphoid tissues in some patients that were treated out to 36 months, we don't see any decrease in the frequency of DNA-positive cells, but the numbers are small. So we can now put a map together, and at least in untreated individuals, we can look and say, what is the burden of infection? If your viral load is 30,000 copies per mil, you've got 5 liters of blood, that turns out to be about 10 to the 8th copies per mil. When you look at the FDC network, that's about 10 to the 9th copies of HIV RNA. 10 to the 8th cells are RNA positive, productive infection, and you have about 10 to the 9th or 10th cells that are DNA positive. And of course, not all of these cells are capable of producing infectious virus. I think Bob Silicano would say that somewhere less than 10% of those are actually capable of producing virus. When you treat patients and you do the same measures, you see this story. So using single copy assay or similar sort of assay, it's not uncommon to find RNA in the blood. We don't know how long the follicular dendritic cell network can remain infectious. It's at least 9 months, but we know that only because they stopped the experiment at 9 months. It's likely could go on much longer. Interestingly enough, when you section all the way through the tissues and when you look carefully in about 30% of patients, you can find evidence for HIV RNA production. And then, as I said, 10 to the 9th, 10 to the 10th cells are DNA positive. Let's look back at those RNA-positive cells under treatment. And this is what you see. Here's a patient who's been on treatment for 10 years, RNA less than 50. Here's a single cell at a different resolution in the lymph node. Terminal ileum sampled at the exact same time. You see the occasional positive cell. Probably reactivation from latency. Don't see much going beyond that. Here's another patient who's been on treatment for 5 years, undetectable RNA. And you see this small focus of infection with multiply positive cells, possibly an expansion in a single isolated location. And here's a monkey who's been undetectable for 12 weeks. And in the colon of the monkey, we see this massive expansion of SIV positive cells, but undetectable in the blood. This is a patient that we published recently before antiretroviral therapy, low plasma viral load, but you can see accumulation of HIV RNA on the follicular dendritic cell network. You put the patient on therapy for 1 month. You probably can't see it very well, but there is a couple of log decrease in signal on the FDC network, and he is undetectable. This is what you'd expect. This is what we think most of our patients are doing, and yet at month 6, undetectable in the peripheral blood. You see that there is a rapid a large accumulation of virions on the FDC network. So when you put this all together and you say, what is happening here? Why is this occurring? In many of these patients, we also simultaneously measured intracellular drug levels at the time of the biopsy in the tissues where we were seeing this evidence for replication. And when you compare those levels to peripheral blood for all but tenofovir, we saw that there was a significant decrease relative to blood in intracellular concentration of the active moiety of the drug in the tissues, suggesting that these drugs maybe are not accumulating in the tissues to the concentration that we think they are, but at least as predicted by peripheral blood. So the dynamic nature of the reservoir over time using these histologic analyses suggests that the frequency of DNA-positive cells does not appear to decrease. 20–30% of well-suppressed patients have evidence for HIV RNA production in lymphoid tissue, and drug penetration is less than would be predicted and may allow for limited rounds of virus replication and perhaps reservoir replenishment. Well, let's take all of that now and bring it back to the Mississippi baby and ask the question, where is this virus coming from and what are the determinants of that using these tissue analyses? Now, obviously, we have not studied the Mississippi baby, but we have another study that we can use to begin to address that question. So we recently published a treatment interruption study to determine the source and complexity of recrudescent viremia. These were 14 patients who were on long-term suppressive ART. They had a lymph node biopsy and a colonoscopy to get ileal and rectal tissues. We then stopped therapy. We monitored peripheral viral load on Monday, Wednesday, and Friday until they were viremic. And then at viremia, we repeated the biopsies and restarted therapy. And first, this was very safe. There was no emergence of resistance and only a transient small CD4 decline. The median time to viremia was 14 days, although it ranged from 5 days to 30 days. And all were suppressed again, a median of 17 days after restarting antiretroviral therapy. What was surprising and interesting was when you looked in their tissues, it told a completely different story. So here are 3 different patients. This is patient 1, 2, and 3. This is lymph node, this is rectum, this is ileum, and you see a follicle here, and this was only 3 to 4 days after we detected viremia. There was a massive accumulation of virus on the FDC network of the lymph node that we sampled in this patient. We also saw a focus in the terminal ileum, simultaneous at the same time. Same thing here with this next patient, rectum and ileum, and in this patient, lymph node and ileum. Now, I haven't convinced anybody, including myself, that this represents anything other than expansion from a single clone of virus, 1 or 2 foci reactivating and seeding to multiple distant sites, as opposed to just explosion from multiple sites when you take antiretroviral therapy off. So to further address that question, we worked with Brandon Keel at NCI and Jeff Lifson's group, who did SGA analysis and full envelope sequencing of each of the patients in the plasma to look for the number of viral variants that were there. And what we found was that most of these patients had multiple variants that emerged at the time of viremia. So this is plasma that was taken on the day of viremia, or if we didn't have plasma then, it was 2 days prior to the onset of viremia. And so this suggests to us that when you remove the pressure, the drug pressure, when you remove antiretroviral therapy, You just get this expansion from multiple tissue sites, in this case, lymphatic tissue. So in summary, HIV disease is primarily a disease of lymphoid tissues. I think there have been multiple studies that suggest that. The reservoir of infectious and potentially infectious virus is quite large. The B-cell follicle is a sanctuary that requires further study. Treatment interruption is associated with recrudescence of viremia, the timing of which may be dependent on the size of the reservoir, and I think there's lots of clues to suggest that. So the last thing I want to say is, what you've heard from Sarah and others and what you've seen here represents an enormous amount of work done on a small number of patients. And I think if we're really going to understand the reservoir, you have to apply all of these technologies to it, as we did in the Berlin patient. Many people worked on these tissues to come up with an understanding for what that cure actually meant. I think, though, as we get ready to introduce cure strategies and cure therapies, really the test is going to be a treatment interruption. And I certainly, for one, would not advocate that we do these intensive studies in every single patient who we're enrolling in a cure study. So with that, I'll stop, and I'd just like to thank all of the patients who have contributed to these studies, the large group of people who have worked hard over the years to make this data possible, our funders, and thank you.